We shall now go on to our next two speakers who are going to talk on a very quintessential topic, VKC, Dr. Vinay Pillai and Dr. Shirish Kumar, and then we'll do a combined discussion. Dr. Vinay Pillai is a senior consultant heading the Cornea and Refractive Surgery Department at Giridhar Eye Institute with a great presence in Kerala and has held many honoris posts in the state societies, and he would be dwelling on the topic vernal keratoconjunctivitis, patterns and presentations. And Dr. Shirish Kumar is a medical superintendent of the Eye Foundation Group of Hospitals, a surgeon of great prowess in cataract, cornea, and refractive surgery, and he is going to discuss the step-ladder approach. So first, we'll hear from you, Dr. Vinay.
Thank you, Dr. Chitra, for having me here. I hope I'm audible enough.
Yeah.
Thank you. So, vernal keratoconjunctivitis, patterns of presentation, that's the topic given to me. Now, allergic disease of the eye is very common, and probably eye is the most common site for development of allergy as it is exposed to the outside world. 20 to 30% of the population have got eye allergies and has a significant impact on ocular health, quality of life, and productivity. There is, over the years, we have seen an increase in prevalence, probably because of industrialization, pollution, urbanization, climate change, and the so-called hygiene theory. So types of allergic diseases commonly are, seasonal allergic or perennial allergic. Then we have the VKC and AKC. And rarely others like contact allergy, GPC, vasomotor, conjunctivitis. Pathophysiology of seasonal and perennial allergic conjunctivitis is mainly type 1 hypersensitivity, which is the IgE-mediated one. And the chronic forms is usually a complex interaction between the type 1 and type 4, and with many non-specific mechanisms. The prevalence of allergic disease in India is supposed to be around 10% or slightly more, with incidence of about nearly 4.5 to 5%. Again, it is seasonal, and it has the study from LVP has shown that it starts rising during early February and peaks during our summer months, May, and drastically fall with the onset of monsoon in our setup. The mean age is around 10. And it usually is more common, in the 3 to 5 age group. The risk factors are mainly males, early to middle childhood, higher socioeconomic class, and history of systemic allergy. Of VKC, we know there are 3 different forms. The most common is the palpable form in India still. Then comes the mixed form, and then quite high percentage of the limbal form too. So VKC is usually a bilateral disease, can be very asymmetrical between the eyes. 23% of them is supposed to be perennial. Of the seasonal variant, 16% is evolved to become perennial over a period of time. Symptoms like any allergies, ocular itching is almost universal. It can be photophobia, mucoid discharge, watering, redness, foreign body sensation, early morning thickening of the lids, a history of severe photophobia, pain, and significant foreign body sensation might suggest early involvement of the cornea. Palpable variety, we know it is a papillary hyperplasia of the palpable conjunctiva. Can be micropapillae, macro, giant papillae, and when these giant papillae kind of coalesce, you get the large flat-topped papillae, which is what we call as cobblestone appearance. And with treatment, as in these pictures, they become much less raised and flat-topped and less, red with time. Maxwellian sign means there is a pseudomembrane on the tarsus, which is basically because of the coagulation of the ropey discharge that occurs. And in chronic disease, especially in the later stages, the eye will be quiet, but you can see subepithelial reticular fibrosis. Palpable, one feature which was described in India is the pigmentation which occurs in the conjunctiva. This kind of brown pigmentation which actually looks like as if walking from the limbus towards the fornix. Conjunctival hyperemia is universal in all of these cases, which is active. In the limbal form, as we know, it is a hypertrophy, or early stages you get the gelatinous limbal papillae, which can be skip lesion initially, and over a period of time, as the disease progresses, it becomes continuous all around the limbus, opaque, thickened. Then you can have yellow spots on them, which is called as a Horner-Trunta spots, which are actually focal areas of mucinous degeneration of epithelial cells and eosinophils, can be associated with vascularization. Cornea usually occurs in severe inflammation. Involvement occurs in severe inflammation. Initially, we get fine punctate erosion. Then they become much more coarser, coalesce and form larger epithelial defect, which eventually can lead to shield ulcer. In chronic stages, you can get whitish, yellowish, discoloration near the limbus, what is called as pseudogerontoxin. This is actually, gray-white lipid deposition in the peripheral superficial cornea. And keratoconus is also quite common in this group of patients. Complications, the major or the commonest one is shield ulcer, which is not that common, though this is the commonest of the complication. It's supposed to be about 0.3% in our population. Can be vision threatening, believed to be either because of rubbing off the large papillae on the epithelium or on the cornea, which is called as mechanical hypoptosis, or because of mediators released from various cells like eosinophils, which is called as chemical hypoptosis. Now, what happens is there is a breakdown of epithelium. The mucus and fibrin accumulate at the or on the base of the this defect, which prevents proper epithelialization, can lead to scarring, corneal vascularization. The three grades of described by Cameron, in which the first grade there is ulcer with a transparent base, then you have translucent, then it becomes elevated because of the base become elevated because of the deposition of the mucus and other debris. Microbial keratitis is not that common, but it is usually secondary to either epithelial erosion or in shield ulcer, which needs workup and management like any microbial keratitis. Keratoconus, again, the described incidence or prevalence varies from 0.7 to 6%, but in the Indian study, it was about 1.4%. The causative mechanism is frequent eye rubbing and leading to microtrauma and inflammatory changes. Also, they have shown, some people have shown that degradative lysosomal enzymes are much more in these keratoconic corneas. So dry eye is another factor which is usually overlooked, and most of the time it is a short tear film breakup type. This is basically because of the persistent inflammation, alteration in the mucus component of the tear film, dropout of the meibomian gland, and reduction in the corneal nerve density. Stem cell deficiency is also described, not that common, about 0.4%, seen in older patients with longer duration of the disease. It can be because of the chronic inflammation of the limbus, which results in poor, limbal stem cell niche support, or can be because of the direct damage by the toxic products of, various inflammatory cells on the progenitor cells.
1 minute remaining, sir.
Lid complications are not, again, that common, but then it can happen in very severe disease. Ptosis is one of the commonest causes, and commonest presentation seen. It can be either mechanical because of the large papillae, or because of the severe inflammation and persistent rubbing. There can be disinsertion of the LPS group. DDs, the commonest one is AKC. Very difficult to differentiate between the two in the later stages, but some of the points that help us, it usually starts in late teens. Periorbital and lid skin are more, involvement is more common in AKC. Inferior palpebral involvement is more common. Then you have more of scarring in AKC compared to VKC. Other comorbid conditions have to be looked for, like dry eye, tear film disturbances, meibomian gland disease, and then drug-induced toxicity or allergies to skin and periorbital area is quite common in these conditions. So these are some of the real good material which all our postgraduates and trainees should actually go through, especially the second one, which is a fantastic data which has come out in the recent Ocular Surface Journal. Thank you.
Thank you very much, Dr. Vinay. That was a